Hi, good evening. My name is Mark Delworth. I'm a urologist in Cincinnati, Ohio with the Urology Group. We're part of Solaris, and we're happy to be joined here by my four colleagues, all from the Urology Group in Cincinnati.
Hi, my name is Steve Bennett.
I'm Brooke Edwards.
Larke.
Brian Minnillo.
Great. Well, thank you for being here. We're going to go ahead and start talking a little bit more about metastatic or advanced castration-sensitive prostate cancer. Dr. Larke, what kind of things do you think about in terms of when you have somebody who presents with metastatic castration-sensitive? Are you going to check any kind of biomarkers? Are you going to do any genetic testing on them?
Generally start with germline testing to get a sense for their mutations that might impact their survival. I don't have any other specific markers that I'm getting. I know there are lots of other things out there in the field, but it's not my routine to get those other markers.
Now, Dr. Minnillo, Brian, a lot of, when you look at the literature, we all say that we should test germ cell, but when you look, it's really not done to the extent that we should. Less than half of patients are getting germline testing. What do you think is the biggest limitation or hesitation in getting those tests?
Yeah, it's a good question. I don't know. It could depend if the patient's coming in maybe to the urology office instead of the medical oncology offices. So maybe some of the urologists are less aware of it than the medical oncologists who are kind of doing a broader family history screen. So that's one thing I've tried to do, is just maybe ask more family history to see if there's other cancers in the family, and then kind of probes to do it. Sometimes the patients seem a little reluctant, actually, sometimes. It seems that, which is surprising, but I try to push it on any new diagnosis, obviously based on the NCCN guidelines. And
Do you think they're reluctant based on worry about what it's going to show, or do you think they're worried about privacy issues, or is it a combination?
yeah, maybe a combination, or maybe the worry of having to go to their family.
Yeah.
But I think once you have a conversation, then they're usually willing to do it. I think it's a hard thing too sometimes, I think, to bring up at the first visit, maybe, because they're not
Right.
at that point, depending on what visit it is.
I think it's a great point. So you're throwing a lot at them right off the bat, and you have to kind of phase that in. Brooke, germline testing, what about somatic testing? Where would that fit into your management?
I think for some of our patients that are presenting, with more severe disease that you're really trying to target, to think of that earlier on. But for most of these patients, when you are further along and you get that sudden progression, you've already failing your other medications, to start thinking through that.
Yeah, and I've started to get it earlier as well. I think when we first started, a lot of us were in that later on, and we're trying to get that really off the bat. Steve, any other thoughts that you have about germline testing?
I mean, I probably don't order it as much as I should. I'm becoming far more aware of it. But a lot of it, as you mentioned, when you're talking to somebody who is, metastatic, castrate sensitive, it's a lot of stuff to throw at them. And I'll be honest, a lot of times, based on severity of disease, how do I know that it's metastatic? Was it conventional imaging? Was it a PET scan? Do they have high volume metastatic disease versus not? I mean, if it's, 5 or 6 years after initial treatment and they're starting with PSA going up and they have low volume disease, I probably don't order it. But I'll be honest that the times that I've mentioned it to them, given the reasons why I'd want to do it, severity of disease, I mean, nobody's ever said no.
Yeah, it's interesting. I'd like to get everybody's opinion. What do you think the positive rate is on those? It's published at 18% or somewhere in that, and I've kind of found out that sometimes it's not quite that high in real life. I don't know what your thoughts.
I agree. Anecdotally, with my patient population, I think it's a little lower than that. I don't know where. Those studies, I think, were maybe a little bit self-selecting for more aggressive disease, little higher chance of having those HR mutations. But
okay.
Yeah. For our overall pool from the Urology Group, our numbers, I think the last time I checked, were a little lower than that.
I think that's
So,
really true.
you know, the one thing I would like to add is, you know, you have a self-selected group because at the Urology Group, our advanced prostate cancer patients see champions. So you guys are very focused on it and thinking of it all the time. But, you know, it was just the other day when I'm talking to one of our prostate cancer, not advanced prostate cancer, but one of our other doctors who are still very hesitant when even recommending Germline, still for the unknown and the privacy concerns and what does that mean for children and grandchildren. And in many ways, because we talk about it so much, I thought we were kind of past that. But it's still very relevant and still something that we need to address for those that aren't ordering it all the time.
I think it's still also very important to have genetic counseling available, you know, for those folks too when things turn up, you know, because, you know, we're not experts in other areas, obviously, and so we have to do that.